Good day to everyone. So I'm again Dr. Romel Bataclan, and I will be discussing the continuation of pharmacokinetics. So as a recap, we have discussed two main aspects, no, in pharmacology: pharmacokinetics and pharmacodynamics. Again, pharmacokinetics is what the body does to the drug or the medication. Pharmacodynamics is the other way around. What does the drug do to the body, or what are its physiologic effect, or any changes, no, in the normal physiology of the body when these drugs are taken. Now there are again three aspects in pharmacokinetics. The one when the drug is introduced or input, and then when the drug is distributed to either the central compartment or the organs with high blood flow, or even to the peripheral tissues or the organs with relatively lower blood perfusion or cardiac output. And today we will be discussing eventually how the drug is metabolized or excreted out of the body, because just like all substances, whether it's endogenous or exogenous substances in the body, they would be eventually be needed to be metabolized or excreted in order to maintain homeostasis of the body, because maintenance of those endogenous and especially exogenous substances can cause toxic or undesired physiologic effects in the body. And then pharmacodynamics is, as I mentioned, is discussed in a different lecture by a different faculty. So again, we have discussed the absorption phase, which is part of the input, and then the distribution part, and then eventually the serum levels decreases because of metabolism, and eventually it is removed or eliminated by the body, either by the kidneys or the liver. So there are two different models. Now, if we would talk about how the drug is metabolized and removed in the bloodstream of the body. So there is what you call the first order kinetics and the zero order kinetics. They are the common models used to describe how the drug is eliminated fast, no, from the body, or the rate of elimination. So this determines how the elimination influences, no, the serum drug levels or the serum drug concentration of the body. So let's go first with the first order. So in first order kinetics, the rate of drug elimination is directly proportional to the concentration of the drug, meaning there's a larger amount of drug, and then there will be a larger drug that is eliminated. With smaller amounts, the rate of elimination would be much smaller, as you can see here. Some drugs that follow the first order kinetics would be paracetamol, aspirin, and penicillin. The half drug of the drug following the first order kinetics is constant regardless of the initial concentration. This means that it takes the same amount of time to eliminate half of the drug from the body, regardless of how much of that drug is present, whether it's the optimal or suboptimal dose, or even excessive dosages that were given to the patient. Now, in contrast, zero order kinetics, the rate of drug elimination is constant. That's why you can see here a linear representation of the graph. So this means there is a fixed amount of drug that is eliminated regardless of the serum drug concentration that is present. So some examples of substances that follows this kinetic would be alcohol, phenytoin, which is a anticonvulsant drug, and in high doses, aspirin. So the half-life of the drug, no, following the zero order kinetics decreases as the concentration of the drug decreases, which means that the time that it takes to eliminate half of the drug from the body will be shorter at a higher concentration. So mas mabilis, no, yung reduction of the concentration by 50% if the serum drug levels are relatively high. Once the drug levels become low, the time for it to decrease that concentration to 50% more would be longer. So Most metabolic biotransformations occur at some point between the absorption of the drug into the circulation and its renal elimination. However, there are few transformations that occur in the intestinal lumen or in the intestinal wall. So most of the time, it's even in the gastrointestinal tract, there is already a beginning metabolism and excretion of the drugs and its metabolites. So in general, all of these reactions can be assigned to two major categories, the phase 1 and the phase 2 reactions. So the phase 1 reactions usually convert the parent drug, as you can see here, to a more polar metabolite, either by introducing or unmasking a functional group, such as a hydroxide, nitrite, and sulfide. Often, these metabolites are inactive, although in some instances, activity is only modified or even enhanced. So sometimes it could be, and the metabolite is the active ingredient or the active form of the drug. In phase 1, these metabolites are sufficiently polar and they can be readily excreted. However, many phase 1 products are not eliminated rapidly and undergo a subsequent reaction in which an endogenous substrate such as glucuronic acid, sulfuric acid, acetic acid, or an amino acid combines with this newly incorporated functional group to form a highly polar conjugate. So, such conjugation or synthetic reactions are the hallmarks of the phase 2 metabolism. A great variety of drugs undergo these sequential biotransformation reactions, although in some instances, the parent drug may already possess a particular functional group that may form a conjugate directly. So, for example, no, the hydrazide moiety of the isoniazid, see here the INH, which is a medication given for tuberculosis, is known to form an N-acetyl conjugate, as you can see here, in a phase 2 reaction. This conjugate is then a substrate for a phase 1 type reaction, namely which is a hydrolysis into a isonicotinic acid. So it's not all the time that the phase 1 comes first before phase 2. There will be certain instances such as this one in isoniazid where in the phase 2, in this case an acetylation phase occurs prior to the phase 1 reaction, as you can see here. Okay, so although every tissue has some ability to metabolize drugs, the liver is the principal organ of drug metabolism. Other tissues that display considerable activity includes the GI tract, the lungs, the skin, the kidneys, and the brain. So after oral administration, most of these drugs, like meperidine, morphine, isoproterenol, are absorbed intact from the small intestine and transported first by the portal system to the liver, where they undergo extensive metabolism. So as we mentioned this in the previous lecture, this is what you call the first pass effect. There are some orally administered medications such as clonazepam, chlorpromazine, which are antipsychotic medications, and cyclosporine, which is a immunosuppressant drug. They are more extensively metabolized in the intestine than in the liver, while others undergo significant intestinal metabolism, such as midazolam, which is an anesthetic. Thus, intestinal metabolism can contribute to the overall first pass effect. So this is also first pass effect, and individuals with compromised liver function may rely increasingly on intestinal metabolism for drug elimination. In addition, the lower gut also harbors intestinal microorganisms, which could be capable of biotransformation reactions. In addition, there's the gastric acid in the stomach, like it could metabolize certain drugs such as penicillin. Insulin can also be inactivated by digestive enzymes, or even in the digestive enzymes in the intestinal wall, such as mga catecholamines. Many drug metabolizing enzymes are located in the lipophilic endoplasmic reticulum membranes of the liver and other tissues. So when these membranes are isolated by homogenization and fractionation of the cell, they reform into vesicles called microsomes. So there are two types, no? The rough microsomes, which tend to be dedicated to protein synthesis, and then the smooth microsomes, which are relatively rich in enzymes responsible for oxidative drug metabolism. So we'll focus on more on the smooth microsomes and its relation, no, or function with regards to drug metabolism. So these smooth microsomes contain the enzymes, no, called mixed function oxidases or MFOs or monooxygenases. So the activity of these enzymes requires both a reducing agent, is usually yung nicotinamide adenine dinucleotide phosphate or the NADPH, you can see here, and the molecular oxygen. So in a typical reaction, one molecule of oxygen is consumed or reduced per substrate molecule, with one oxygen atom appearing in the product and the other in the form of water. So in this oxidation reduction process, so there are two microsomal enzymes here. So the first one would be a plavoprotein. So you can see the here. Okay, the NADPH cytochrome P450 oxidoreductase, or we call the P450 reductase, is another enzyme here. Okay, so but we'll go first here. No, there's a P450 reductase. So one mole of this enzyme contains 1 mole of each flavin mononucleotide and flavin adenine dinucleotide. So FAD or FNN. And then, so they are oxidized. They undergo oxidation reduction reactions. So the flavoprotein gets the electron from the hydrogen ion from the NADPH to go into its reduced form. And now, that reduced flavoprotein now directly interacts now with the second enzyme system, which is the P450. So now what happens here is that this one, no, the oxidized iron P450 combines with flavoprotein, which is usually ito na yung and then there's also the drug substrate here. Yan, the drug substrate, I'm sorry, here. Okay. And then when that drug and the P450 complex combines, it reacts with the flavoprotein. So the flavoprotein donates, no, an electron to the P450 drug complex, okay, and converting it into a oxidized P450 drug complex, as you can see here. Yeah. Okay, so a second electron, as you can see here in this step, is introduced from the NADPH by the same P450 reductase, or even yung microsomal cytochrome B5, which serves to reduce molecular oxygen and to form an activated oxygen P450 substrate complex. And then this complex in turn transfers activated oxygen to the drug substrate to form now the oxidized product. So, and then this cytochrome P450 is used and recycled to further metabolize yung drugs or particular metabolites, no, that maybe the intestinal enzymes or gastric enzymes or even the gut microflora has initially have reacted to. So there are various genes, no, that encodes multiple enzymes, no. So there are so much variety that of P450 isoforms. They can modify many structurally diverse substrates. So in addition, a drug can act as a substrate of more than one form or one type of cytochrome P450. So for example, the four enzymes here, the CYP3845, the CYP2D6, CYP2C89, and the CYP1A2, they are responsible for the majority of P450 catalyzed reactions. CYP34A, for example, this one, is found in the intestinal mucosa, which metabolizes drugs such as chlorpromazine and clonazepam. The enzymes also exhibit genetic variability among individuals and racial groups. It can affect either the efficacy or it can cause a preponderance of adverse events. So CYP2D6, for example, okay, leads to poor metabolism of certain medications. So an example here is codeine, which is a opioid drug which could sedative effect. So what happens is because of changes or racial differences now in the form of the CYP2D6, there are certain forms of CYP2D6 which are poor metabolizers, which prolongs the effect of codeine and hence the possibility of adverse events such as prolonged drowsiness or sleepiness. And then cytochrome P450 can also be affected by presence of certain substances or medications. So there's such thing as inducers. So this means it increases the enzyme activity, leading to significant decrease in plasma drug concentration. So because of inducing or stimulating cytochrome P450, it increases its ability to metabolize drugs, and therefore it could translate to decreased efficacy of certain drugs that are metabolized by the cytochrome P isozymes, as you can see here. So what are some of the examples that you can see here? So for example, the CYP2C9, okay, in which uh, metabolizes these particular drugs. So they're inducers. So for example, the patient is a diabetic, glimepiride, and then at the same time, the patient also has a seizure disorder, and the patient is on phenobarbital. Glimepiride may not be as effective in treating diabetes because phenobarbital is a inducer of this isoenzyme, meaning it increases the metabolism of glimepiride. Therefore, its blood glucose lowering effect is also affected or decreased or markedly decreased. CYP3A45, which is also a common isoenzyme, um, can metabolize these medications. So the problem is, like for example, if you give erythromycin, which is an antibiotic, and the patient again has a seizure disorder and is taking phenobarbital, the efficacy of the antibiotic may also be affected or may be decreased because phenobarbital also is an inducer of this type of cytochrome P isoenzyme. If there are inducers, there are also inhibitors that decreases now its metabolic activity, so increases plasma drug concentration, which on one hand may increase efficacy of the drug, but balancing it could also lead to a possibility of higher chances of adverse effects or drug toxicity. So some examples would be in ketoconazole, which is an antifungal drug, erythromycin, again, which is an antibiotic, and ritonavir. Okay, so these medications usually inhibit more than one type of P450 isoenzymes. Particularly yung ketoconazole. So ketoconazole is an inhibitor of certain cytochrome enzymes. So an example would be this one, the CY3PA45, cyclosporine. We usually give cyclosporine in post-kidney transplant patients as an immunosuppressant. So we usually give ketoconazole in order to increase the availability, the serum levels of cyclosporine in the body. Therefore, we tend to start the cyclosporine at a lower dose, which would theoretically save the patient some money. Okay, but we have to monitor definitely the serum drug levels of cyclosporine, so because we don't want the levels to be in excessive amounts because it may lead to certain adverse events that we don't like, especially in a relatively immunocompromised state, such as post-kidney transplant patients. So going back, so here are some phase 1 reactions. So yung epinephrine is oxidated and the amine group is separated from the side chain. There could be dehydrogenation, such as yung alcohol and aspirin, which is an antiplatelet. There's also yung addition of a hydroxide group, such as in lidocaine, which is an anesthetic, indomethacin, which is an NSAID, and there could be also nitro reductions. You can see here. Some examples would be chloramphenicol, which is again an antibiotic, and clonazepam, which is an antipsychotic medication, and carbonyl reductions, meaning an addition of hydrogen in the oxygen side chain. So naloxone and methadone, which are also anesthetics, would be an example that undergoes these types of phase 1 reactions. So parent drugs, or their phase 1 metabolites that contain suitable chemical groups often undergo coupling or conjugation reactions with an endogenous substance to yield drug conjugates. So in general, these conjugates are polar molecules that are readily excreted and often inactive. This formation involves high energy intermediates and specific transfer enzymes. So these transferases may be located in the microsomes or in the cytoplasm. So common or dominant enzyme here would be yung uridine 5' diphosphate glucuronyl transferase, or the UGTs, which you would see here comprise most of the enzymes in the phase 2 reaction. Okay, these microsomal enzymes catalyze the uncoupling of an activated endogenous substance with the drug, or sometimes it can also affect yung mga endogenous substances such as bilirubin, which is an end product of heme metabolism. So cytosolic and microsomal glutathione transferases, so yung mga GSTs, are also involved in the metabolism of drugs and other substances. Chemicals containing an aromatic amine or hydrazine moiety like isoniazid are substrates of cytosolic and acetyl transferases encoded by NAT1 or NAT2 genes, which utilize acetyl-CoA as its endogenous cofactor. So here are some of the examples of phase 2 reactions. As I mentioned, glucuronidation. Okay, there's also acetylation using acetyl-CoA like isoniazid and clonazepam. There's also, it could also conjugate with the glutathione, such as paracetamol. That's why glutathione is given in paracetamol poisoning, which we will discuss later. Sulfation, or adding a sulfide subgroup. So again, paracetamol would be an important reaction here, and we will discuss that later. Methylation would be adding a methyl group, so dopamine, epinephrine, which are important in the in inotropes for cardiovascular support. And then there's also water conjugation as well. So as I mentioned, there are changes, genetic alterations or polymorphisms. So polymorphisms are variations in the DNA sequences that occur naturally within a population. This variation can lead to differences in the structure and function of the proteins. So going back to what I mentioned earlier, so cytochrome P450 enzymes have multiple genetic polymorphisms that can happen. So what its effect? So again, as I mentioned earlier, if the drug is metabolized too slowly because of that polymorphism, it can lead to toxicity. If the drug is metabolized too quickly, on the other hand, which could also be a form of polymorphism, it may not reach therapeutic levels, which would lead to drug resistance or less efficient delivery of the drug, even in the recommended doses. There are also drug-drug interactions that may occur, which alters the metabolism of one drug and then eventually affects the concentration of another drug. So what is the importance of genetic polymorphism? While it's still in the works at present, Eventually, further studies and hopefully the further understanding of genetic polymorphisms would lead to personalized medicine, meaning we can help to tailor drug therapy in certain individual patients, in order to improve treatment outcomes and minimize adverse events. Genetic information can be used to identify individuals who may be at risk for adverse drug reactions. So this will lead to a more effective drug development and again, minimizing toxicity and adverse reactions to patients. So hopefully, with further understanding of genetic polymorphisms of various cytochrome P450 enzymes, uh, that would also explain why certain medications are ineffective to some individuals and for others, why certain drugs would cause certain adverse events which are undesired to certain people. So these are other examples of genetic polymorphisms. Okay. So this is found in the Katsu. Okay. So as I mentioned earlier, gut microflora, which can also be involved in drug metabolism. So remember, the human gut is a home to a diverse community of microorganisms, of gut microflora, which has various physiological processes. One, of course, would be protection against pathogenic microorganisms. But drug metabolism can also happen, or some microorganisms are involved in such reactions or um, metabolism of the drug. So some modify the structure of the drugs through biotransformation. This can lead to formation of metabolites that may have different pharmacological properties than the parent drug. Some bacteria would activate the prodrugs, converting them into their active form. They can also detoxify, meaning it reduces the toxicity of the drugs because of the action of the bacteria. And then the metabolic activity of the gut microflora can influence drug-drug interactions by changing or altering the drug concentrations in the body. So what are some drugs affected by the gut microflora? So for example, digoxin, which is a cardiac glycoside, yung bacteria in the gut can metabolize digoxin. So therefore, it lessens already its toxicity because the problem with digoxin is there's also preponderance to adverse events and toxicity when it accumulates at high serum levels. Levodopa, which is anticonvulsant drug, and gut bacteria can also metabolize this drug. Okay, this is also a drug, given in patients with Parkinson's disease. Oral contraceptives can also be influenced by gut microflora, which can affect the absorption of estrogen and progesterone in the gastrointestinal tract. And there's also the antibiotics, which could be a problem, because it can eliminate this gut microflora. So therefore, it could also affect metabolism of certain drugs if there are other medications that are taken by that individual, in addition to given antibiotics for a particular infection. So in addition to the presence of antibiotics or other medications, the diet, so the composition of the gut microflora is influenced by diet. So intake of prebiotics and probiotics can improve the population of gut microflora and therefore helps in regulating the gut physiology, protecting it from pathogenic microorganisms, and also helps in the ensuring the balance in terms of drug metabolism if the patient is taking certain medications. However, there are also certain diseases that in the gastrointestinal tract, such as inflammatory bowel disease, irritable bowel syndrome. It also affects the composition of the gut microflora and, of course, yung ability to absorb. So therefore, the efficacy of the drug can also be affected if there are disease states in the gastrointestinal tract, affecting not only the absorption and eventual distribution of the drug to the body, but also in the metabolism of these drugs as well. So now, let's why it's very important to learn about metabolism of certain drugs. So let's talk about paracetamol or acetaminophen toxicity. So now paracetamol, so usually it's given in tablet or oral form. So paracetamol is metabolized in the liver. Majority of the paracetamol undergoes what you call a glucuronidation reaction, which is a phase 2 reaction. And then the next one would be at least 2/5 would be sulfonation. And both of these reactions would form non-toxic metabolites which are excreted by the kidneys. However, in certain instances, especially if the paracetamol serum levels goes up, it now is metabolized, although in a very small proportion by the cytochrome P450 system. So the problem with that is its metabolite is what you call the NAPQ1, which is a toxic metabolite. And then there's an endogenous glutathione in our body which binds with NAPQ1, which would eventually be a non-toxic metabolite as well. So it's eventually neutralized, no, by glutathione. Now, the problem is if there is acetaminophen overdose, no, typical scenario would be since it's readily available, it's an over-the-counter drug. Some people would take it for a dose for suicide. Okay, so usual dosage of paracetamol would be 500 milligrams. So let's say that the patient or an individual took about 20 tablets. So that's about 10 grams of paracetamol. Now the problem is these enzymes would have a limit. They would be saturated. Okay, so there's a limit in the reaction. Even though there's a recycling that occurs, that recycling takes time. No, once those enzymes have been are metabolizing the paracetamol. So now you're now activating now the cytochrome P450 metabolic activity here. And you're increasing because the rest of the paracetamol dosage now increases now the production of NAPQ1. And eventually your glutathione stores can also be depleted. So because of that, overdose depletes glutathione, there's accumulation of this toxic metabolite, and now this binds to hepatic proteins. It causes cellular stress leading to hepatic necrosis. Okay, but before that, the NAPQ1 circulates through the blood. It indirectly stimulates in the vomiting centers in the medulla. So usually the initial stages of paracetamol toxicity would be nausea, vomiting, and anorexia. Because vomiting is one of the ways that the body would try to eliminate undesirable substances in the body. But excessive NAPQ1 will now go to the liver, leading to hepatic necrosis, and now eventually through time there is already now signs of liver dysfunction. So there is right upper quadrant pain. Sometimes you would measure the liver enzymes. There is already elevated SGPT, SGOT, and elevated internationalized normal ratio, or the INR. So it's already affecting the prothrombin time. And then the toxic NAPQ1 causes extensive hepatic necrosis, leading to now a severe complication, a fulminatic hepatic failure, which will lead now to jaundice, hepatic encephalopathy, decrease in sensorium, and initially comatose, and it could be fatal in a relatively significant proportion of individuals. So that's why one of the important medications given for paracetamol or acetaminophen overdose is N-acetylcysteine, because it binds with the NAPQ1, which is similar to glutathione. So when you bind it with the NAPQ1, you're already neutralizing it, making it a non-toxic metabolite, and hopefully you eliminate it um, through the urine or through the kidneys. So it's very but this is a very important case, no? So because there are significant cases, no, number of cases in our country that would have paracetamol toxicity. And then one of the tests that you should also perform here is yung determine the serum drug levels of paracetamol. Unfortunately, it's not readily available in most centers, no? Especially in Nueva Ecija. Okay, so there are other factors, no, that could affect yung drug metabolism. So diet, environmental factors contribute to variations, no, in metabolism. Like charcoal broiled foods and cruciferous vegetables are inducers, no, or particularly CYP1A. Grapefruit juice, for example, now is on the other hand is an inhibitor of the CYP3A drugs. Cigarette smokers also metabolize some drugs more rapidly than uh, non-smokers because it's also an inducer of certain cytochrome enzymes. Increased susceptibility to the pharmacologic or toxic activity of drugs has been reported in very young or in very old patients compared to young adults. Although this may reflect differences in absorption, distribution, and excretion, differences in drug metabolism can also play a role. Slower metabolism can be due to reduced activity of these metabolic enzymes or reduced availability of endogenous cofactors. And then there's also sex-dependent variations, although most of these are based on animal studies. Usually these differences are much more consistently been associated in the androgenic hormones. Although there are some case reports that have implicated sex differences in drug metabolism, particularly in alcohol, ethanol, propanolol, which is a beta blocker, some benzodiazepines, estrogens, and salicylates, or yung aspirin. And then many substrates, no, by virtue of their relatively high lipophilicity, are not only retained at the active site of the enzyme, but it could be not specifically bound to the lipid endoplasmic reticulum. In this state, they may induce microsomal enzymes, particularly after repeated use. So acutely, depending on the residual drug levels at the active site, they may also competitively inhibit metabolism of a simultaneously administered drug. And then there's also yung mga enzyme-inducing drugs, no? Such as, mga sedative hypnotics, such as carbamazepine, antipsychotics, anticonvulsants, the anti-tubercular drug rifampin, and insecticides. Patients who routinely ingest barbiturates, other sedative hypnotics, or certain antipsychotic drugs may require considerably higher doses of warfarin. So as you can see here, warfarin can be extensively metabolized because of some of these drugs if they are concomitantly being given to the patient. On the other hand, discontinuance of the sedative inducer may result in decreased metabolism of the anticoagulant, and there could be a bleeding tendency. So the effect now of warfarin can now be exaggerated once these medications are discontinued. So you have to be cautious in adjusting the dose of warfarin if these medications are discontinued or decreased in dosage. So again, those are some examples. So itraconazole, which is also another antifungal, you can see here, it can affect metabolism of vast number of medications from different indications or diseases. So, as I mentioned, drug could be excreted through the gastrointestinal tract by fecal removal because of it can mix to the feces, or it could be eliminated through the urine by the kidneys. So most drugs are passed to the kidneys as part of the glomerular filtrate. So remember, since kidneys is one of the organs with high cardiac output, so there's a certain percentage of drug that could go to the bloodstream of the kidneys, and then it passes through the afferent and the efferent arteriole, passing through the glomeruli, no? And then that free drug, it goes to the glomerular filtrate, it filters out, and then eventually goes to the tubules. There are some drugs that could be actively secreted, no, by the proximal tubule, and then eventually going through the other segments of the tubule, from the loop, the distal tubule, and then there will be instances that there could be a passive reabsorption, no, particularly of lipophilic and ionized medications, no, especially there is the increased luminal concentration here. So there is again the diffusion that happens, no, from an area of high concentration to a low concentration. But for most of the time, particularly for hydrophilic ionized drugs, they are eliminated by the urine. So therefore, it's very important. So once the function of the kidneys has been compromised, definitely metabolism and eventual elimination of the drug could also be affected. That's why chronic kidney disease is a very important topic, no? Especially when we're dealing with management of medications among these patients. So essentially, chronic kidney disease is a dysfunction, no, of the uh, the kidney's ability to maintain homeostasis. So therefore, you waste materials, which include drug metabolites, would have limited excretion. There would be acidosis. There would be hypertension, fluid retention, electrolyte abnormalities, anemia, etc. So further build up, no, especially of the nitrogenous waste, no, as reflected in the blood urea nitrogen or BU and serum creatinine. And if there are symptoms or clinical manifestations, no, related to the accumulation of BU and creatinine in other middle molecules, that's where the uremic syndrome happens, or uremia. So now uremia can have an effect on the pharmacokinetics, as you can see here, no. So what happens? So it decreases, no, the protein binding. So therefore there is an increase non-renal clearance. So it can make the drug less effective because of increased clearance. So particularly if that drug is metabolized, no, by the liver, or not by the kidney. It could definitely have an effect on the liver metabolism. It could decrease expression of these cytochrome enzymes. It could increase this presence of cytokines, leading again to downregulation of the cytochromes. Elevated parathyroid hormone, it could affect the bone mineral metabolism as well. There's allosteric binding. So all in all, it decreases, no, the cytochrome expression. Therefore, it could affect your metabolism, decreasing metabolism, and there is a possibility of accumulating metabolites, or even the parent or the active drug in the body that would cause increased chances of adverse events. So this is relatively important, no? Especially in drugs with narrow therapeutic indices. A narrow therapeutic index means there is a small margin between the therapeutic dose and the toxic dose. So because when there is a narrow range of concentration, a minimal increase, no, of the serum level of that particular drug can already tilt, no, the balance of a possibility of undesirable effects in the body. So some of the examples are here, no. aminoglycosides, no? Amikacin, gentamicin, again, cardiac glycosides such as digoxin, lithium, which is a antipsychotic drug for mood disorders, warfarin, which is an anticoagulant, and phenytoin, which is for seizure medications, amiodarone, which is an antiarrhythmic drug, insulin, given, and yung mycophenolate and tacrolimus, no, which are also medications for um, immunosuppression in kidney transplant patients. So therefore, dosage adjustments, blood monitoring if possible, like tacrolimus, no, we monitor tacrolimus serum drug levels and clinical monitoring. So if there's no clinically available serum monitoring, we have to do clinical monitoring. No? Like particular example, in warfarin, we check the INR. In insulin, we check the blood sugar. So those are some clinical parameters that we use in lieu, no, of measuring the direct serum drug levels. So these are some of the important things or drugs that you have to take note of, no? Especially if that individual would have a chronic kidney disease. So without going now to the details, no, of CKD, because that would be discussed in future lectures. So, but it's very important to have a good history and physical examination. And then you have to estimate the glomerular filtration reaction, or the person, or plainly speak, the percentage of functioning kidneys in the body. You review current medication so that there could be there's a possibility of drug-drug interactions which might affect, no, whether increase or potentially decrease the effectiveness of certain medications. You calculate individualized treatment regimen, now depending on the estimated GFR. Now you monitor the parameters, whether there are serum drug level tests or there could be other clinical parameters to be used, and you adjust the dose accordingly. So you usually use yan, yung mga estimated GFR equations. So the most ancient here would be when I was a med student, Kakrop and Gold. But now it's more of the MDRD that we use. You don't have to memorize these equations. It is available in the med calculating calculator apps. So it's very easy to compute, no, the EGFR using these apps. Now, based on that estimated GFR, and in addition, you also have to measure also the urine albumin in order to determine or classify its stage. So you classify it not just based on the estimated GFR, as you can see here, but also on the level of the albuminuria that the individual has. So as you can see here, so if, for example, no, the estimated GFR would be 72, which is here, and then the urine albumin creatinine ratio would be 2 milligrams per millimole. So here, so green, meaning there is a very low risk, no, of development of end-stage renal disease. But for example, if the eGFR is 28 and the urine albumin creatinine ratio is 50 milligrams per millimole, so here, nandito siya sa may red spot, which means there's a very high risk of developing end-stage renal disease that would necessitate renal replacement therapy or dialysis, which means the dose adjustment in these patients would be much more stringent, therefore lower doses than what is usually recommended must be given to these patients. So these are some of the examples now. So here, this is a some of the anti-TB medications. So as you can see here, so stage 1 to 3, of course, there are some drugs that you have to adjust depending on also on the weight of the individual. And then eventually there's some, the frequency in a week is reduced. But there are some, like isoniazid, as you can see here, hindi siya nagbabago, no? Because isoniazid is primarily metabolized in the liver. So hindi naman siya renally excreted also. So there are some medications that does not need those adjustment in the presence of chronic kidney disease. However, no, there could also be chronic liver disease. So there are acute or chronic liver diseases that can affect the structure and function of the liver, which affects definitely a metabolism of some drugs. Alcoholic hepatitis, cirrhosis, hemochromatosis, biliary cirrhosis, viral or drug-induced hepatitis are some of these disease entities. Depending on their severity, they may impair the enzymes, the microsomal oxidases, and therefore affects drug elimination. So, for example, yung diazepam, which is a sedative drug, okay, the half-life of it is increased. Therefore, it takes a much longer time for it to be metabolized. Therefore, its effect, no, its sedative effect would be much longer. These drugs can even cause coma in patients with liver disease when given in the usual doses. So, some drugs are metabolized readily, okay, that even marked in reduction in liver function does not significantly prolong their action. However, there is what you call an interaction between the heart and the liver. So, in presence of cardiac disease, wherein there is a decrease, no, cardiac output and blood flow to the other organs, in which liver also gets a high proportion of the cardiac output, can impair disposition of certain drugs whose metabolism is flow limited, such as these medications here seen in this table. So these drugs are readily metabolized by the liver, that hepatic clearance is essentially equal to the liver blood flow. The impaired enzyme activity or defective formation of enzymes associated with heavy metal poisoning or porphyria also results in reduced hepatic drug metabolism. Going back to this slide, yeah, the Child-Pugh score. So this is so kung the kidney has a categorization based on the estimated GFR and the albuminuria, there's also the Child-Pugh score, which is a classification system to assess the severity of the chronic liver disease. It evaluates liver function based on 5 factors. First one would be encephalopathy, also in the sensorium of that individual. Ascites, which is the presence or absence of fluid accumulation in the abdomen. There's also the INR. Again, measure of the blood clotting time. Serum albumin, which is, of course, the major protein produced by the liver and the major protein of that can that binds, no, to most, if not all, drugs. And bilirubin, which is a breakdown product of the red blood cells. So a higher Child-Pugh score indicates a more severe liver disease, and this score is crucial for determining the prognosis of chronic liver disease and guiding treatment decisions. So therefore, again, the liver disease can cause decreased drug clearance. It can alter drug distribution because of decreased serum albumin. It therefore affecting its pre-concentration levels as well. It can impair the absorption of certain drugs in the gastrointestinal tract, and in certain cases, the patients can be more sensitive to the effects of certain drugs, even if you lower down their dosages. So again, some of the drugs affected by chronic liver disease, again, paracetamol, as you can see, the reactions that happens in the liver. The opioids can be also impaired in chronic liver disease. Clearance of certain antibiotics such as erythromycin and clarithromycin, and beta blockers also, which are antihypertensives. So, yeah. So, those reduction though is much less clearer, no, in liver diseases, no, but there are some recommendations that can that are given it's very important also to read, no, in the whether in the textbook or yung mga clinical information in the journals or yung mga clinical leaflets that you will found in the drug preparation itself. It's very important to read if there are those adjustments that can be that's needed to be made, no? Especially if you have a patient with a end-stage liver disease or liver cirrhosis, or those with advanced stages of advanced Child-Pugh stage, no? Because it might have a uh, undesirable effect, no, in giving the standard or the usual recommended doses. So in summary, so we have discussed the pharmacokinetics. So we have discussed the input, meaning how the drug is administered and goes into the body, how the drug is distributed initially to the organs with high proportion of cardiac output, and then how this drug is eliminated to the body after its use. So there are clinical implications. Therefore, knowing these very important concepts would help you manage these patients and be more observant and wary of the drug's physiologic effects and also its adverse events and undesirable effects that could happen in an individual. So with that, thank you for listening. And if you have questions, you can email me anytime soon. Thank you and good day.